Migraine headaches. Well, first of all, what is a migraine headache? How does a little kid tell you that he's having a migraine headache, especially if he's not at an age? How often do we see them? I don't remember that I saw very many. So it's a real quandary. And here to talk about it this morning is Alyssa LaBelle. Alyssa is an associate professor of anesthesia at Harvard Medical School and an assistant in neurology and an assistant in pain medicine. She is a senior associate pain medicine at Children's, as well as director of the pediatric headache program. She graduated 5'8" with a bachelor's in psychobiology from Wellesley and an MD from Tufts, where she was AOA. She has many other honors and prizes, including a 2016 award for headache research. She's involved in the last several years in 12 nominal studies on headache. She's mentored more than a dozen postdocs and has lectured everywhere from Brockton to Newport Beach, California, and Beijing, China, and Nieuwegein, Netherlands, to Milano, Italy. Wow, your passport must be gorgeous. She has a large bibliography of articles in peer-reviewed books and journals. Her work is largely in three areas: clinical care, teaching, and the ongoing study of the neurologic generation and modulation of persistent pain. Dr. LaBelle.
Well, thank you for that very kind invitation and introduction. This is a remarkable hospital, and I can't believe it's my first time here, and so thank you for having me. I'm speaking to you on a topic today that if you are interested in headache issues, your news feed on the phone is probably going off the rails today because there is a new group of interventions for adult migraine. There are trials in pediatrics that involve monoclonal antibody injections for binding to a certain receptor that's very important in modulating headache pain, the calcitonin gene-related polypeptide receptor, or CGRP. So there have been 4 companies working diligently over the past 4 years to get this drug out. It's for chronic migraine. And the first one just launched yesterday. So I just have to mention it's a Narinab. They're all named similarly as monoclonal antibodies. But you'll see a lot of information, I think, coming out. So it's timely. Of course, it's a little different in pediatrics. This is just I have nothing to disclose. And what I wanted to cover, we can go briefly through it, and I'd really more like to focus on questions, is how you diagnose, a little bit about pathophysiology, only as it guides our treatment, a little teeny bit about genetics, it's ever increasing in importance. The acute treatment, I have some slides that you can just keep on the chronic treatment, and what the future holds. So just to put it in perspective, epidemiologic studies of chronic pain, and I usually deal with headache more as a chronic issue. It doesn't come to me if they're just one headache every few months. These chronic pain issues, the prevalence has been really all over, because we don't have great data yet in pediatrics, and that's true as well for migraine and for headache in general. It's quite a large range, but it feels very common as opposed to, I know your own experience, that I run a chronic headache clinic, and I feel like it's a major health problem. So it's just in terms of one's own patient population. So this is just the recent international classification of headache, the ICD-10 3 beta. It's now 3. There are many different types of headache, and if you really look at this classification scheme, you will find hundreds and hundreds of different types of headache in great detail. But the four basic categories are, of course, migraine, tension-type headache, the less frequently seen in the pediatric population, but not impossible not to see in the pediatric population, the trigeminal autonomic cephalalgias. And then a group of miscellaneous headache problems that have yet to be pathophysiologically characterized so that they can belong to the right section. And the prevalence that we touched upon just a moment ago is, something that's a work in progress, but clearly it is not rare. And of course, among females after puberty, those numbers increase greatly. It's due to effects of estrogen on brain connectivity, which we've started to explore. But there clearly is a female predominance. And the clinical importance, which I often have to sell to neurology residents or anesthesia residents that think that headache seems fairly trivial, it's not. The morbidity is certainly acute, and the mortality is not as great as other issues, but the morbidity is very large. And even as a burden of disease in the world, it's the seventh worst of all disabling conditions. And it's an expensive problem. It includes a pediatric subset that is increasing, and it really offers us an opportunity in pediatrics to look at a problem that can create a major health difficulty early, independent of other risk factors, and try to understand really what the mechanisms are. This is just from one of my colleagues in imaging, looking at what happens with frequent headaches, and this is just a plea to pediatrics. There's an increasing burden, an increasing stress to the developing nervous system that ultimately might result in a very frequent headache pattern in adulthood, and so we have to intervene early and effectively in a multifactorial way to prevent frequent headaches when recognized. Sort of the same theme as the last speaker, intervene very early. We call this the allostatic load, and over time you can find a number of stressors that contribute to an increasing burden of headache. This is, of course, what we really worry about as pediatricians in headache management. We worry about the secondary causes of headache. This is not the most frequent presentation to the ER or to our clinic, for sure, but it is what we always are concerned about. And so just to touch on quickly, what are the ways to look at secondary causes. This is, of course, also the greatest concern of the family. So tumors, which are not intracranial tumors, are not uncommon in pediatrics. They're probably the third most common tumor. Structural abnormalities, like this posterior fossa Chiari malformation, which might or might not be clinically significant. And post-traumatic, which, if you really count the fact that a significant intracranial injury has happened with concussion, maybe not so much the mild concussions, but more severe, that really expands the secondary causes of headache to a larger field. But other issues are temporomandibular joints, sinus infections, vascular abnormalities, AVMs, arteritis, intracranial hypertension. That would be a talk unto itself. But that's another major issue to discuss, and chronic infections. Interestingly, though, Epstein-Barr virus or mono-like infections can be one of those many stressors that lead to chronification. Intracranial tumors, common. However, thankfully, less than 1% of the children who have headache with tumor have no other symptoms. So it's very important to elicit a very detailed history. And really, greater than half of the patients who ultimately present with tumors have more than 55 neurologic symptoms. And what are those? Well, those features are predominantly, the most commonly found neurologic symptoms associated with secondary headache are ocular. So diplopia, blurred vision, ataxia, sort of really falling into the walls, not just developmental clumsiness, but really ataxia, and of course any progressive symptoms. There has been a recent report in headache that also, of course, frequent nausea. And there's always the fear that the nocturnal headache or the headache upon awakening in the morning, is a very significant finding. It is a significant finding, but probably not as great as these particular neurologic signs. And across any headache that is progressing, inexorable. So recurrent pediatric headaches that are primary are much more common. So after you rule out your secondary causes, or at least feel somewhat confident, this is going to be where most of the patients fall, into primary headaches. And again, back to prevalence data, which we always get from Scandinavian countries because they keep such wonderful records, that it's an equal male and female preponderance before puberty. In fact, it's a little bit more frequently presenting to clinic as males in early childhood. But of course, it takes off as a female predominance after puberty. And in pediatrics, we can't do the most wonderful studies that are done in the adult world because our patients don't really fall into neat patterns of headache taxonomy. They usually are mixed. There are patients who have episodic tension, and then they'll have some periodic migraine with aura, maybe rarely present, but more likely without aura. So the mixed type is more of a pediatric presentation, which kind of gives a complication to collecting the data. And many people ask, well, if you have headache in childhood, is it going to go away in adulthood? Because that's what we all hope for. And there has been some indication that having a Y chromosome might be more useful for that after puberty. But it's not perfect. Many patients do go on, if you truly follow them, to have recurrent headache, especially if they've had the addition of a number of stressors over time. Now, the definition of migraine in pediatrics is just a little different than the definition in the adult world. The things that are different are that it might be shorter, it doesn't have to be unilateral in terms of presentation, even if it shifts sides, and that you can kind of assume that there are features of photophobia and phonophobia and maybe even osmophobia in these patients from just hearing their history. They don't, of course, need to describe that in great detail. However, children's drawings are the best way to really get a good handle on what the patient is feeling. And that's what we often do in the clinic. If a patient is willing to draw a picture of their head, that can be very helpful and discuss that presentation. Things that are common to adults as well is that migraine headache is moderate to severe. It is not mild. So the rating of that headache needs to be higher. And it has to be either associated with nausea and or vomiting, or photophobia and or phonophobia to make the criteria. And migraine with aura, rare in children, but still present and very useful when present to treat early, is the same definition as is present in the adult taxonomy. So that an aura usually is not present for greater than an hour. The only difference in that is hemiplegic migraine, a very, very rare migraine variant. The weakness on one side of the body can last for several hours, if not 24 hours, into the headache itself. The thing that's sort of interesting in pediatrics that you don't see as much in adults is that pediatric patients have a developing brain, and so they present with a very different array of headache problems that might not be clearly associated with headache, and are important to differentiate or to be aware of, because this might be confusing when the patient presents to the ER the first time to urgent care with some of these symptoms, and that they ultimately are headache symptoms. Benign paroxysmal torticollis, usually present in younger patients before age 2. But benign paroxysmal vertigo is not an uncommon presentation in the pediatric population, and by default becomes a premonitory symptom for headache. Patients who present with vertiginous symptoms in childhood are much more likely than the general population to develop vestibular migraine in later life. In fact, any presentation of a sensory symptom can be ultimately associated with migraine. Migraine is a disorder of the brain, and so anything that produces a change in sensory functioning can be ultimately associated with migraine. Acute confusional migraine is the toughest one because it appears like stroke, but as we know, the etiologies of stroke in pediatrics are limited, but it always engenders a lot of attention in the ER and a vigorous workup. So what are some of the more common presentations of migraine variants? Well, everyone probably is very well aware of cyclic vomiting, and this is the definition that's offered by International Headache Association. It's not uncommon. It's in 2.5% of school children. It's very stereotypical, with repetitive vomiting, at least multiple times. And of course, all of these patients have seen a gastroenterologist by the time they would get to me. But hopefully it will be recognized earlier without needing endoscopy. Abdominal migraine is not belly pain with headache. Belly pain with headache is regular migraine. But abdominal migraine is that you have recurrent attacks of abdominal pain. The gut is filled with serotonin receptors. And those receptors, as they develop in the gut as well as in the brain and communicate with the brainstem, will fire off in an episodic fashion, just like would happen in migraine. And so abdominal migraine is just pain independent of headache, localized to the abdomen, and is probably the scourge of the school nurse. So you have to have at least these features, and of course many of them have had other evaluations. This is just a schematic to show that area in the middle, which is really the brainstem, that's the periaqueductal gray. There's this periaqueductal gray, and the rostroventral medulla. This area is a great convergence area for lots of things that happen in the brain, especially primary migraine, and things that happen in the gut. So there's no way of really separating those out, and so many times when we have patients who have irritable bowel syndrome, we will treat them with serotonergic agents, or we will treat them with migraine preventives. Benign paroxysmal vertigo, this is just the definition. You have to kind of accumulate a number of attacks of severe vertigo. And vertigo is a very interesting symptom, very complex, and needs to be teased out in the history. And usually, of course, they see our vestibular colleagues and are told they have central vertigo and not a peripheral vertigo abnormality. And this is the autonomic nervous system, because everyone who has recurrent headaches ultimately, through the pain transmission system, activates features of the autonomic nervous system. So it's very interesting if you look at your patients. Many patients with chronic migraine will have other features that are not a new disorder. They're just activating their autonomic nervous system. So they might have orthostasis. They might have gastroesophageal reflux. They might have flushing, color, temperature changes, clamminess of the hands and feet, generalized fatigue. And it's not that they have a number of diagnoses. The headache is the activator of that system. Basilar type migraine is not frequently seen and is now being called posterior fossa or brainstem headache, because all these features are referable to the brainstem. But you will see this variant in pediatrics, which is again a concerning variant and usually prompts imaging. Tension type headache, the other primary headache that's not migraine and very common, the prevalence is also quite broad, but of course the primary treatment is more multidisciplinary and involves psychological interventions, not because they carry a DSM-5 diagnosis, but because that is the most effective intervention, that and exercise. And then chronic daily headaches. One might think, this seems uncommon to have a patient report headache every day, but that's all we see in my clinic. And we have thousands of patients, so I think it's not that uncommon. I hope, because the brain is more plastic in a developing individual, that we can have an impact and transform this headache subtype back into a more intermittent and less disabling variant. But the types of headaches that you can see might be associated with medication overuse, because we, as human beings, want to give our children who are reporting pain every day something, and not a good idea. Chronic migraine can just be transformed from episodic migraine to chronic. Chronic tension type is just a level of tension type headache pain, more mild, but present on a daily basis. New daily persistent headache pain is an entity that we're trying to understand, that has been defined in the adult population as an all-day, everyday headache pain with migrainous features that has an onset, usually without a premonitory or a prodrome of episodic headache before it. It just sort of comes out of the blue. It might be coming out of a history of concussion, repetitive concussion, or repetitive infection. But it's all day, every day, and it's the worst to treat. It doesn't respond to any migrainous therapies. They only are 25 or 30% effective in reducing a little bit of the intensity. It has to be treated with a multidisciplinary approach, and we're increasingly trying to understand it as more of a neuroinflammatory or vascular etiology, that there are changes in the endothelial function and the supportive cells around the neurons in the cortex, overlying the cortex, where all those pain receptors are. And hemicrania is a less common presentation, but very responsive in most patients to nonsteroidals. So this is NDPH, our new daily persistent headache. And usually it doesn't arise out of overuse of analgesia. But I do think this is an increased presentation. Chronic migraine can arise out of analgesic overuse. If you're suddenly getting more migraines and taking more meds, symptomatic meds, then you likely will develop a more daily pattern. And unfortunately, once you are on overuse of medication, just stopping the overuse of medication does not take away the headache. It really requires time and, again, the multidisciplinary approach, because there has been increased sensitization in the pain transmission system producing that frequent headache. And in fact, some of those changes in those important areas in the brain have occurred because of the analgesic overuse. So again, it's only about 30% of using a prophylactic, and a prophylactic won't even work unless you stop the daily use. And medication overuse in children is, of course, not uncommon. Not that they're seeking it, but because we, as their caretakers, feel a strong need to relieve their pain. If it goes on for a long time, it becomes a major issue. And the non-progressive headache is usually what we see after concussion. There are many patients who have had mild concussions that quickly recover, and then there are those patients who go on to have headache as their primary post-concussive symptom. And if we follow the post-concussion guidelines of cognitive and physical rest, we will be following cognitive and physical rest until their wedding. So it's very important to be able to make a judgment of when it changes and intervene appropriately as a chronic headache versus an immediate post-concussive symptomatology. And we have to assess disability. Chronic headaches are certainly associated with disability, and I think most people are familiar with this scale. There are many functional disability scales that you might prefer. This is from Andy Hershey's group at Cincinnati, and if you just look at what they're asking about, they're really asking about school. So that becomes a very important marker of disability in this patient population. The genetics of migraine are very interesting and require enormous amount of work and are very heterogeneous. There are multiple alleles involved in transmitting headaches among families. But it's a very interesting pursuit. Certain ones seem to be more important. But we've always known that headache is multifactorial and that it's familial. And we've seen many genes over time be associated with migraine, but not consistently. The familial hemiplegic migraine variant, that very rare migraine, has probably given us the best window genetically into the etiology of episodic migraine, because there have been at least 3 identified genes that code all 4 sodium and calcium channels. So that helps us understand paroxysmal migraine and some of the trigeminal autonomic cephalalgias as a channelopathy, very much like other channelopathies that you might see in neurology, like the hereditary ataxias. But this has helped us kind of understand that pathophysiology. This is one of the first identified genes in the hemiplegic group, the p-keto calcium channel. And so if you have hemiplegic migraine, of course, you would choose a calcium channel blocker, but it's probably not going to be that frequently seen. But it has allowed us to understand the disorder better. But really, it's not all about the neuron, it's not all about the sodium channel, it's also about the supporting cells, and even in that very specific subtype of familial hemiplegic migraine, there are other receptors on other supportive cells that are important and are probably important targets of treatment, especially going forward. And some of those involve inhibitory interneurons, but very importantly glial cells that have not been a target of pharmacology until recently. More genetic studies. A lot of the visual migraine aura patients will have a genetic abnormality as well as changes within the visual cortex when we do functional imaging, which is a sort of interesting variant. And so if you do happen to get an EEG, not that that's recommended, for patients who present with primary headache, you might see some occipital spikes. That does not mean that they have epilepsy. It just means that they have an active occipital cortex. Sleep has, of course, like in every chronic problem in pediatrics, has increasingly played an important role in understanding chronicity. And we have recently identified within the past few years the hypocretin orexin system, and that release of substances binds to the hypothalamus as well as to the pain transmission system for headache, and is extremely important in being able to provide a kind of top-down inhibitory influence on pain release. So if there is no regular sleep, then you have to know that no other treatment for chronic headache is probably going to be effective. This is a very primary system that goes from the middle of the brain to the important hypothalamus and pain transmission system. This is just to show that headache falls among all those other channelopathies in terms of genetics. And this is just to review that, of course, again, headache is not just the pain. It is also the premonitory symptoms, the prodrome and the postdrome. And it's an evolution over time, and you need to ask about what's happening, because if you know the prodrome, you can intervene at that time, even before onset of pain. This is an unfortunate picture of the pathophysiology of headache, but the reason that I bring it out is just that over time we have understood. You see those little vessels over here? I wonder if I can get them. Where are they? These vessels. These are really sitting in the lining of the head. So that's why when you bounce your head back and forth with repetitive concussion, or you get infections, or you have meningitis, or things that might activate dural nociceptors, dural pain receptors, that can sensitize that system. And those nociceptors in the dura are loaded with pain receptors, but also with nociceptive chemicals, like that calcitonin gene-related polypeptide that the monoclonal antibodies are all about. And if you activate that, the first step in the pain cascade in migraine is that there is a direct communication with the trigeminal ganglion. So some people, when they're starting to feel their headache, feel it right behind the eye, because that's the referral base. But then the next step, the important step, is that it gets down to the brainstem. And whether it activates the brainstem or not depends on our wellness and our balance. The brain is very Zen-like within a number of connected areas of the brain. And if we are too permissive, then this area will always activate. This is called the descending nucleus of the trigeminal nerve, the nucleus caudalis, or as we refer to it, grand central station, for all head and neck pain processing. So if someone also has a lot of ear infections, throat infections, eye problems, dental issues, even whiplash, that can prime this area. Once this area is released from inhibition, it's a multi-neuronal collection of receptors, it will send the information to predominantly the frontal cortex. It will send some information to the occiput and cause neck spasm. It will activate its neighbors in the brainstem, and as everyone knows, in the brainstem it's a very dense neighborhood. So it will activate the nausea centers, which are right over here, and the vestibular centers, and the fatigue centers, and then the light and noise and sound centers, and then you get the full-blown headache. Which is why also, because those centers can intervene on behalf of activation in this area, that's why we use anti-nausea medications, IV in the ER, to abort severe status migrainosus. And that's the primary treatment, because already this has changed its stripes, and there are more excitatory neurons in here than inhibitory in status migrainosus. So it's hard just to use a pain medication like ketorolac to block it. But we've increasingly understood this. The things that we don't understand in headache, they're still out there, are how does a environmental trigger translate into a neuronal firing pattern, be it activating cortical spreading depression that might give you an aura, or activating the dural nociceptors. We don't know that, but we know what happens once it happens. And we know a little bit about this from the pain literature. We know how potent the superior areas, the cognitive modulatory areas of the brain are in dampening activity down in the brainstem. That if we really want to turn off that excitatory center down in the brainstem, we need to activate these centers for good. And those important centers primarily reside in the cingulate cortex and in the prefrontal cortex. And they are activated by cognitive biobehavioral therapy, practicing relaxation strategies briefly, but every day for months, in order, because the brain is a little slow to make these new pathways. But if you do practice those, as well as maybe acupuncture, the data is just coming in. But if you do these activities on a daily basis, you will produce a superhighway from those pain inhibitory centers in the cortex to the pain transmission center in the brainstem that are called, in functional neuroimaging, default mode networks. And we can see these form now, so it's very exciting. We always knew that that was a useful intervention, but we can see what it produces in connectivity changes in the brain. And this is just to show that from animal data, and this is true for humans as well, that the thalamus and the trigeminal vascular system, that descending nucleus of the trigeminal nerve, is where it's at. Everything has impact on this area to reduce or to disinhibit the possibility of pain. So looking at this, sleep, depression through 5-HT receptors, GABA through those upper cortical areas, obesity, everything has an impact on the natural activity of this center, and so, of course, treating chronic headache is multifactorial. And this is what we've learned from imaging. So this is an old slide of areas, regions of interest in the brain that are important in producing pain or reducing pain. And it includes that hub, the thalamus, it includes that brainstem area, but it also includes a lot of areas that people, before we had imaging studies with activation, didn't know that those other parts were involved, including the cerebellum is sometimes involved. So it is restoring balance among all of these connections that is the key to treating headache. And again, just to review some old neuroimaging data, when we first started to look, we could even trace out the trigeminal pain pathway in headache patients in terms of activation, so then we could intervene and see what things could be done to change in real time in a non-invasive fashion. And we could even tease out areas that are emotional pathways that are important in pain modulation, as well as sensory pathways, because pain is not one or the other. It's always a combination of both. And we were finally able to kind of delineate what each area was primarily doing so that we could focus on that in terms of pain management in general. In pediatrics, we recently embarked on using these imaging approaches to try and understand pediatric pain and especially pediatric headache. And initially we started out with activating areas of the brain, putting patients into the magnet and activating, touching, doing sensory studies, showing visual stimuli. But now we're predominantly looking at resting state networks, which you need no activation for. The patient just lies in the magnet, and we can see which connections are being made at baseline. We also can look at structural changes. Interestingly enough, multiple headaches can increase or decrease gray matter structure. You can see altered processing in diffusion tensor imaging. Everyone who has a concussion now gets diffusion tensor when they get their MRIs, and that shows connectivity. If you have dropout, it shows axonal injury. We can look at metabolic release, neurotransmitters, metabolic markers of either neuronal density or other sensory activation. And in infants, we're using cortical activation to look at responsiveness to pain because it's a very non-invasive approach. This is just showing some of the diffusion tensor imaging. So if you have a dropout of connectivity up here, this occurred after, you see kind of a dropout here. You can see that that's a secondary indication of axonal injury and probably speaks to a longer recovery. And then this is a resting state network that we looked at between children and adults who had episodic migraine, and children had appropriate connectivity between regions of interest involved in pain sensitivity and pain modulation, and as they went through puberty, they dropped out their connections to the periaqueductal gray, and as they got into adults with episodic migraine, they even had less appropriate connections. And this is a study that we looked at for why is it that females have all these headaches or pain problems in general. And these are just showing that in those same kind of resting state approaches to life, There is quite a change between girls and boys in terms of connections between those regions, and we believe that it is all estrogen based, and there are even changes in the cortical structure. And enough with that, and turn to treatment. This was an old practice parameter that came out years ago that told us what we already knew, that EEG is not recommended and that neuroimaging is not recommended for most cases that seem to meet clinical criteria. That doesn't mean that we don't obtain it if we don't have a fair amount of anxiety or any specific concerns. And that in pharmacologic interventions, there's very little data to support what we do. So this looked at findings from 1980 to 2003, and found, yes, ibuprofen is effective. That was earth-shattering. Acetaminophen, maybe. Sumatriptan, maybe. And there was no level for a lot of the triptans. Subsequently, we've gained a lot of information about the triptans for primary migraine. So this was another slightly later review looking again at these same potential treatments, showing that we still didn't have the greatest data a few years later, differentiating among the triptans, but we did have some data for using that anti-nausea medication, especially acutely. Preventive treatments have worse data. It's really all over the place. There was insufficient evidence in this older trial to recommend anything above, more of a psychological-based treatment. So this was their closing statement, which I always liked, which is sort of sums up pediatrics. Use your good judgment, because the trials are not all there to provide evidence. In the adult world, there's a better hierarchy because there are more specific placebo-controlled trials. And these are the levels, A, B, and C, of recommending agents in adulthood. But this does not apply in pediatrics. I have another slide that tells you why. This is what applies in pediatrics. This is the non-pharmacologic approach to headache management. And of course, we've talked about this, many speakers have talked about this, regular sleep, regular meals, regular exercise. In the brain world, it's 20 minutes of aerobic exercise 3 times a week to release endogenous opioids and endorphins and enkephalins from the periaqueductal gray to bind to that brainstem area. So that's what we recommend when patients are a little reluctant to be motivated to do sports. So they just have to get to that level. And of course, stress, anxiety, depression. And therefore, we use cognitive biobehavioral therapy, biofeedback, sometimes acupuncture, physical therapy, massage. And this is sort of the basic treatment. This is just a stressor, chocolate. So the acute treatment of migraine is somewhat summed up in some of these things that we have here. I want you to know that we have FDA approval for almatriptan, zolmitriptan, rizatriptan. We have rizatriptan down to 6 years of age, so no one should fear using a triptan in that age group. That's the proper dose and proper instruction. Triptans are the only medications that are migraine specific. Everything else is a pain medication. Everything else is to modulate brainstem function in the setting of chronic pain and frequent headaches or chronic pain. It is not specific to migraine. Triptans are the only ones that can work upstream at the level of the dural afferents, at the level of the connection to the trigeminal ganglion. So if you have an aura, that's really lovely because you can treat at that time and block pain transmission to the brainstem itself. But everything else that we use for headache is generic pain medication. I haven't done all that much better in terms of its use. And the way that triptans work is that in part they're serotonin agonists at a specific serotonin receptors. There are like 40 serotonin receptors, so depends on which one you're going for and where it is in the pain transmission system. And it inhibits that very important grand central station, trigeminal nucleus caudalis transmission. It gets to the dura, and it gets to CGRP. And it also promotes vasoconstriction. So it's a multimodal effect with triptans. And this is where we think that it works, on blood vessels, trigeminal ganglia, and in that important brainstem area. They're only differentiated among their pharmacology. Some are a little faster, some are a little slower. If you get chest pressure or muscle contraction with one of them, then switch to another one. These are the slower ones. Frovatriptan is what everyone knows for menstrual migraine because it's long-acting. And things to be cautious about. People have to be very cautious in the adult population because coronary artery disease is a major limitation, but don't often have that in peds. There was a consideration that maybe if you had all those brainstem symptoms, that wouldn't be so good, but we have no evidence that the vasculature in the posterior fossa is affected by triptans. So that is no longer considered to be a contraindication. Hemiplegic migraine, not so clear. Serotonin syndrome risk is low, even if we have our patients on SSRIs. They're going to be using these intermittently. They're not made to your day. You're not going to get a serotonin syndrome. And the FDA approval, as shown. Antiemetics, you saw where that works in the brainstem. These are important cofactors. We usually combine them with something for pain, a triptan, and an antiemetic at earliest onset because of that synergistic effect. And this is the ER. Again, headache is a common ER referral in pediatrics, more common than in adults. In adults, it's about seventh in, not third. Viral infection, of course, is more common. Sometimes in our ER, hydrocephalus is the most common diagnosis, or questions of whether or not the shunt that has been placed 20 years ago is still working. So we still have to deal with a little bit of the pressure issues. But really, it's primary headache that's more common. And of course, the goals are preventing rebound and getting fast relief. And so again, IV antiemetics are the mainstay. That's the recommendation at present. We might then move on, if we get no response, to a steroid or to valproic acid. It's used more frequently now. Sometimes, if you really want to try to break a chronic cycle of migraine, you might admit the patient to the hospital for a couple of days and do an IV, a very potent form of a triptan, dihydroergotamine, an old drug, dating back to our knowledge of the witch trials in terms of ergots and agitation. But in appropriate dosage, that's not seen very frequently, and it can be an effective way to break a cycle. The side effects, though, are more potent than the oral triptans, and so you just have to prepare for it, and that should be done in-house because you have to give pre-treatment with antiemetics and muscle relaxants. There are new delivery systems for all the triptans that will be better for pediatrics, that don't even involve needles, if you want to get it in fast, that are nasal. I think that increasingly they should be used as an appropriate agent as part of the armamentarium. In most of our pediatric patients, I think people are somewhat reluctant at times. Now, you might ask about Botox. Everyone asks me about Botox, and it's not, of course, approved above 18, so it's hard to get insurance coverage. And this is not an inexpensive treatment. But having said that, our understanding of Botox and headache is not what it does in spasticity. It is not muscle relaxation in the muscles around the scalp. It penetrates in part through suture lines to the dural nociceptors. It also gets peripherally to the trigeminal ganglion. And it has an effect on those pain-relieving compounds that are so important in reducing pain. There's more data to be done, to be collected, but it's a different mechanism for headache than it is for spasticity. And this is just to remind you, that there are many other cells involved after nerve activation that we're also trying to target in treating chronic presentations of headache. These are what we have as the drugs for chronic headache. I just gave you this list to have, but I can't recommend one above the other. We usually choose them on the basis of their side effect profile: weight loss, sleep, agitation, tremor, high sympathetic tone. You might use propranolol. Anorexia, you might use cyproheptadine. So there's no way that we have enough data to recommend any one over the other, like in that adult hierarchy. And we maybe even have a little bit better data for the supplements. It's not perfect, but we have some data for magnesium, coenzyme Q10, a couple of herbs, butterburn, feverfew, and riboflavin. So if a patient is having chronic headache and their diet does not contain enough of this, it might be useful. And what about the adjuvant therapy? So I told you about botulinum toxin. Nerve blockade is truly an adjuvant. If someone has a lot of occipital irritation or muscle tightening, this can be added, but it should never be felt that this is the primary treatment of headache. And acupuncture. We have some data as well. This is what we don't have data for, and we are also asked about this on a daily basis. This is like the new kid on the block. I've been on everything except for this. But we do have data that we can interfere with those frontal connections that are made until you're 26 from a number of areas in the brain. And there's clear evidence that there is developmental inhibition. And a lot of our colleagues in Europe who have been using this agent more than we have that data. So this is not something that we recommend to the developing brain. It's the THC that is the agent. Oh, that's not it. Okay. It's the THC that's probably the active pain medication because it co-localizes with opioid receptors in the pain transmission system. But we don't know about the cannabidiols in pain transmission as yet, though I have many patients who use cannabidiols. We just don't have that. We understood it in terms of the endocannabinoid system based on the THC. Having said that, we do know in general pain management that infants who are exposed to a high level of painful procedures, such as in the NICU, do have alterations in their endocannabinoid systems, and therefore probably in their ability to modulate pain. So it is a very interesting area of research, but it is not ready for prime time. And this is, of course, the most important part that we treat in pediatrics, the family. And a chronic headache disorder involves the family. And it takes us back to Psychology 101, when we were thinking about kind of developmental psychopathology, that what we're going to deal with mostly is industry versus inferiority, if you believe in Ericksonian stages. And there it is. It's the middle childhood period. And if you do not present a different kind of approach to treating self-esteem and allowing the patient to be in sports as appropriate or at school, you're going to end up with a chronic headache patient. And so this is where we intervene, most notably at this stage, before identities are fused to chronic pain. You don't want to fill out those Social Security disability forms too early. So we want to make a change. And this is to just remind us that sometimes it has nothing to do with the patient. It has everything to do with the family. And so that's why you cannot exclude the family. This, of course, says, if you can't read it, I have to be getting back. I'm the glue that holds my parents' marriage together. Sometimes a chronic issue is what's important in a family dynamic. And so there's no way of treating chronic pain or chronic headache without working with family dynamics. And children, just like adults, have a downward spiral of disability. We need to intervene with increasing physical vulnerability, increasing somatic symptoms. Many of our patients with one chronic symptom morph into something else: pseudo-seizures, chronic abdominal pain, limb pain. So intervene early. And what do we do to intervene? Well, we use things like biofeedback. It's been a very useful intervention to teach children how to control their own autonomic nervous system. We activate this top-down system that we talked about. And we have probably our best data for these non-pharmacologic interventions than we have for pharmacologic interventions. If you go to the Cochrane database and you review, you'll not find much on pediatric pharmacology, but you'll find a great deal on cognitive biobehavioral therapy. And in fact, if you just do cognitive biobehavioral therapy with the family, you'll have a better effect. And we have increasingly tried to sort out what patients are at risk and how to intervene, and this is one of our group's risk models. And it's very important to identify resilience factors, fear factors, and because that activates those parts of the brain that create a chronic pain state, and try to achieve success. One thing I do want to go back to say, that in terms of pharmacology, I think everyone knows that in the New England Journal of Medicine last year came a report of the first and might be only placebo-controlled trial of looking at pharmacologic prophylaxis in pediatrics, comparing amitriptyline and topiramate to placebo in chronic migraineurs in a pediatric population. And we were one arm of that. There were many groups, because in pediatric studies you have to combine many groups to get your data. With that study, it was stopped by the NIH halfway through. And what happened is that placebo was way and above more effective than topiramate and amitriptyline. And topiramate and amitriptyline also, of course, had more side effects. So they just stopped the study, had to stop enrolling halfway. And, there are many interpretations of that study, and one thing might be that placebo was enhanced in the study because it allowed the patients to be seen more frequently and to have contact with their primary caretaker. But